In your mind, what do you think some of the greatest advancement for treating this disease?
Well, it depends on when you frame it, Steve.
In the last 5 years, I would
All
say,
right,
perhaps.
because you can tell from the intro that I'm kind of a one-trick pony here, and I have been doing this for a while. And I'm going to go back a little bit more than 5 years because I think the trends are interesting, evidence-based, and really quite sustained. When I first started melanoma, surgery was the only treatment for it. And surgery was quite radical. Surgery, because I think there was nothing to fall back on. We really didn't offer patients other than a lot of surgery, whether it was a bigger, wide excision or more extensive lymph node dissections. And we even tried to take out we tried to handle metastatic disease with surgery because, again, we had nothing else. Two things have happened, and I think they're very sort of complementary. One is that the surgeons, even before there were effective systemic treatments available, but started worrying that we were doing too much surgery. And so there began a series of very structured, I think probably pretty brave at the time,
Sure.
randomized clinical trials to minimize the amount of surgery done. And that first started with margins of excision around the primary melanoma, which, as you know, when I started out, were big 5-centimeter incisions. And now we're trying to do little, 1-centimeter incisions, even on the worst melanomas, in the context of clinical trials. And at least as far as the primary melanoma is concerned, evidence-based prospective randomized clinical trials have really informed a dramatic improvement in minimizing surgery without compromising end results. That, in turn, as you well know, bled over into management of lymph nodes, where we used to take out lymph nodes in everybody. And now we're very selective about who, if anybody, requires a lymph node dissection in the presence of normal lymph nodes. This was the Sentinel lymph node revolution in surgery that was really inspired or spearheaded by Don Morton. But even after Don died, that movement has continued as we are trying to figure out who, if anybody, needs clinically negative lymph nodes removed. And that kind of evidence-based paradigm shifts, I think, are they've been really important, and I'm really proud to have been a part of all of that, because it's the same results for less surgery. Then if you sort of fast forward to, I'd say, the last 8 or 10 years, not just the last 5, there's been this, I guess, confirmation of something we've always thought was the case, but could never quite put it in a bottle and use it for treatment. And that is that melanoma is highly responsive to manipulations of the immune system, or even to attacking some of the unique genetic drivers that promote growth of melanoma. And that's that immune therapy, which I really believe was largely birthed at Memorial Sloan Kettering Cancer Center, dating back to the days of the Ludwig Institute and Lloyd Old and Alan Houghton, have been translated by their acolytes. And I would say acolytes, Jed Wolchok being the champion of this, but Paul Chapman, into the effective use of much more active agents. And this would be the Yervoy, the anti-CTLA-4 antibody. And that was really Jed Wolchok led that trial. Then to the PD-L1 story, which is more effective, less toxic immune therapy. And then Paul Chapman explored the efficacy of the targeted agents against the half of the melanomas that have this BRAF mutation. So the last 8 to 10 years have been kind of, in my way of thinking, kind of the natural evolution of the minimizing of surgery. At the same time, we've developed now and I'm going to call it effective systemic therapy. I think, when people talk about effective systemic therapy, they think I'm saying it works in everybody. It doesn't. It certainly doesn't. And there's a lot of work left to be done in terms of overcoming things we call primary resistance, which is it doesn't work the first time you use it, or acquired resistance, meaning it worked for a while and then stopped working. And so, in essence, all of the research now, it hasn't stopped with this tectonic shift in how we treat patients with advanced disease, but we're now attacking the new questions that all of these new drugs are arisen. I'll say one thing, and then I'll stop talking for a minute, and that is that the survival of patients with metastatic melanoma, not so much primary or even lymph nodes, but the survival, when you had metastatic melanoma, that was a death sentence, and your average survival was measured in a few months. Now, your average survival is measured in years. That's an enormous shift in the way we think, compared to the time when we had no treatment that made any difference, none at all. So that, when I say effective, I mean effective compared to the old days. We have not solved the problem of melanoma. There are lots of questions left to go. Maybe we get into those, but for the most part, we're shrinking surgery with equal effects. And most importantly, I think we're actively developing newer, more effective agents to deal with non-surgical disease.
Thanks for that, wonderful summary. And a lot of great context. And I think the word you use, brave, I cannot imagine back then, for the surgeons to try to reduce the surgical margin. That is a series of really brave surgeries.
Brave patients.
Yeah. And